Thank you, everyone, for joining. We will be a few minutes before we get started as people get situated. We'll give it one more minute and start at 2:31. Thank you, everyone. All right, I think I still see some people streaming in, but in the interest of time, we'll get started. So thank you everyone for joining us today at a Canada's Drug Agency webinar about the Pan-Canadian strategy to improve the appropriate use of prescription medications. I know it's a busy time of the year, heading into the holidays, so really appreciate you taking time to join us. I'm Jonathan Lam, Director of Appropriate Use at Canada's Drug Agency. I have the pleasure of speaking with you today about the appropriate use strategy on behalf of the team. This work is all really made possible from insights from our advisory committee, the incredible team here at CDA-AMC, and the foundational work of Health Canada's Canadian Drug Agency Transitions Office Appropriate Use Committee. Back in February of this year, we engaged with many different interested parties for input about the draft appropriate use strategy to help finalize it. On September 18th, we launched our Pan-Canadian strategy to improve appropriate prescribing and use of prescription medications. And today we'll be taking a closer look at the appropriate use strategy and what it means for patients, clinicians, and decision makers across Canada. Next slide, please. We'll get started today with the land acknowledgement. Canada's Drug Agency recognizes the traditional territories, rights, and diversity of all First Nations, Inuit, and Métis communities across Canada. Indigenous peoples have been and continue to be excluded and harmed by Canada's healthcare systems. In the spirit of reconciliation, we're committed to addressing these inequities alongside Indigenous communities. I would like to begin by acknowledging that I'm speaking to you today from the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. I would also like to acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit, who have been keepers and stewards of this land over many generations. I'd like to encourage you all to think about where you live, work, and play, and take a moment to acknowledge the peoples who traditionally occupied, sustained, and continue to care for the land that we call home. So before we get started, a couple housekeeping items. So there is a Q&A feature for you to submit your questions at the bottom of your Zoom screen, and you see that icon with a question mark and a dialogue bubble beside it. It's important that we keep respectful, professional, and safe environment. So please keep that in mind as you submit your questions today. We will be reviewing the Q&A as the day goes on and answer questions at the end of the day. We'll try our best to get to as many of them as possible. If not, we will be addressing them post the meeting as well. And to note, we are recording this webinar and will be posted on our YouTube channel. So I'm honored today to be joined by three panelists from our Appropriate Use Advisory Committee. They'll be offering their own perspectives based on their wealth of experience in this area. First, we have Connie Newman, a lived experience partner. Connie is an executive director and lead consultant for the Manitoba Association for Senior Communities, which has 89 member groups. The association leads Age-Friendly Manitoba and social prescribing initiatives across the province. Among many of Connie's volunteer engagements, she's involved with St. James Assiniboia 55+ Active Living Center and the Friends of the Living Prairie Museum. She's a primary caregiver for a friend residing in the community and another living in a personal care home. Connie is 77 years young and holds a master's degree in education administration from the University of Manitoba. Next, we have Dr. Jim Silvius, one of our co-chairs on our committee. He's the co-founder of Canadian Medication Appropriateness and Deprescribing Network, or CADEN, and is a clinical professor at the Division of Geriatric Medicine, Cummings School of Medicine at the University of Calgary. He's also a senior medical director for seniors health at Assisted Living Alberta. Last but not least, another co-chair on our committee is Stephen Samus. He's a health policy consultant, adjunct faculty at the Cummings School of Medicine, and a member of the O'Brien Institute for Public Health at the University of Calgary. He was a deputy minister of Health and Social Services at the government of Yukon from 2017 to 2022. Previously has worked for multiple pan-Canadian healthcare organizations, including CIHI, and has extensive experience in federal, provincial, and territorial government relations, health policy, population health, and health program delivery. And you'll be hearing from our three panelists shortly. So thank you again for joining us. So our objectives for today, really three things. One is to gain a better understanding of appropriate use and why a strategy as action is needed now. To learn more about the strategy and what it's about, and then get a glimpse of some of the work that we're already moving forward with the appropriate use space. In terms of agenda, it really reflects what the objectives are. You're hearing from different perspectives from our panelists about why their strategy is needed and how the strategy will work to improve appropriate use. And as mentioned, we will have a dedicated time at the end for Q&A. So please enter your questions throughout the webinar using the Q&A function at the bottom of your screen. So next slide, please. So I'll be setting up the stage on why the strategy is needed, and then after that, opening it up to our panelists to answer a couple of questions. So at this point, you might be wondering, next slide, please. Thanks. You might be wondering, what is appropriate use? And many of you will be quite familiar, and some of you may be new to this. So really, appropriate use is defined as when patients, caregivers, healthcare professionals work together to choose safe and effective medications most suited for that person's needs and goals to achieve best health outcomes. We all know that prescription medications are an important part on how people manage their health. However, we also know that when it is not used appropriately or when they're used inappropriately, it can increase the risk of harms like drug interactions, falls, hospitalizations, and even death. In Canada, 1.9 million seniors regularly use at least one potentially inappropriate medication. And in a 2021 study, people in Canada spent $1 billion on potentially inappropriate medications. So one specific example of potentially inappropriate use is the use of antipsychotics to treat behavioral symptoms of dementia where a patient has no diagnosis of psychosis. In Canada, from CIHI indicator, we know that 1 in 4 residents living in long-term care take antipsychotics without diagnosis of psychosis. So 1 in 4 residents are potentially taking an inappropriate medication on antipsychotics. The good news is that we know there's a lot of excellent work and different programs in Canada already looking to tackle this problem of appropriate use and improving the use of prescription medications. However, there's limited coordination at this time across these programs. In other words, greater coordination, greater collaboration could really increase the reach and impact of these organizations through collective actions and impact. And now you've heard a lot of me speak. Now I'll turn to the next slide and discuss with the panelists their perspectives on these issues. Next slide, please. Or maybe we can close the slides down for now. So first question for Connie. As a member of the public and experienced patient partner, from your perspective, what is needed to support patients' involvement in appropriate use?
Forgot to turn the microphone on. Good afternoon, everybody. As an older adult and involved with the Appropriate Use Committee, I've learned a lot. And one of the things that needs to happen across Canada, an awareness among all of us, all of our patient partners, and an understanding of what appropriate use is. Some patients, some of my friends have been in this space using too many drugs for too long. And they have to get the knowledge that we now have about appropriate use. We need to educate the public. We need to educate senior serving organizations. And our health system is fragmented. People have been seeing different doctors. Some of them have gone to different clinics. And there's no, well, I know in Manitoba, the number of platforms, electronic platforms exist. They're not talking to each other. So therefore, I, as a patient, need to talk to the doctor I see about appropriate use. Very, very important.
Perfect. Thank you very much, Connie. Next, I'll turn to Jim. You're a geriatrician and a founding member of CADEN, or the Canadian Medication Appropriateness and Deprescribing Network. How have approaches to medication management changed over time?
Thanks, John. So as you heard, back in late 2014, I and another geriatrician in Montreal, Kara Tannenbaum, met to discuss a national approach to appropriate use of medications by older adults in Canada. She was researching methods to help address overuse, and I was a clinician and a decision maker with an interest in trying to ensure that older adults were being prescribed medications that were appropriate to their needs, both those they should be on and those that they potentially shouldn't be on. Many people will be aware and familiar with lists such as the Beers list that identifies potentially inappropriate medications for older adults. Some people will be aware of tools to address both overuse and underuse. But in general, efforts to better assist with more appropriate prescribing have been siloed and with limited spread, as you've already heard. There are harms to both overuse and underuse of medications, including adverse effects, hospitalizations, and even death. There are also costs to individuals, families, and the healthcare system. Out of this, CADEN was born with the purpose of helping to advance appropriate use of medications by older adults. Over the last 10 years, medicine has evolved, and our approach to medications has also evolved. Multiple medications now are being used for conditions where previously one would be used, which presents challenges. What happens when there's a side effect? What is responsible? How do people keep track of taking all the medications that they need to be taking? In late 2021, CADEN actually proposed a draft national strategy because of a desire to see a national approach to what we felt to be an increasing problem, and that has continued to be the case.
Thank you very much, Jim. And last but not least, Stephen, I'll turn to you. You had the unique perspective of chairing both Health Canada's CDATO advisory use or appropriate use advisory committee and also our advisory committee here at Canada's Drug Agency. What stood out to you about what you've been hearing across the country about the need for this strategy?
Thanks very much, John, and hello to everybody online. I think what really stood out for me through the process of engagement that we did under the Canada Drug Agency Transition Office process, and then with this process through the CDA, was really the strong consistency in what we heard. Through the CDATO process, we engaged well over 200 people. Those included providers of various types, patients, industry partners, governments, and others. What we heard through that process was really echoed again when CDA went out and also then re-engaged with people, many of the same kinds of people that we engaged with the first time, but then also different perspectives in the second round. And the consistency between those things was really striking. So it really gave us the sense that we were on the right track, that consistency. So it was a really nice process, and it really helped us to understand that we gave us the confidence to think that the strategy that we were developing, that the work that we had done through the CDATO process to advise Canada's Drug Agency was a really good, fulsome effort and stood us well to develop the strategy.
Great. Thank you, Stephen. Thank you, Jim and Connie. And your reflections really kind of set us up for why there's a need for this strategy. And I think in the next phase of this webinar, we'll be talking a little bit about both how the strategy was developed And then actually the meat of the strategy, what are the goals and how are we planning to kind of move forward? So next slide, please. So like Stephen said, this is really built on a couple different ways and a rigorous process in building upon the recommendations that Stephen just talked about, the CDATO work, and also inputs from our own advisory committee, which all our panelists today are part of as well. In addition to that, we also held a number of additional engagement sessions, both with our provincial, territorial, and federal government partners to hear their thoughts and insights, but also many other interested parties, including other appropriate use organizations across Canada, equity-deserving populations, health system partners, so these include prescribers, clinicians, healthcare organizations, as well as academics and researchers, patients, caregivers in the public, and also industry. We also had the opportunity to participate in a sharing circle hosted by Caden with a small group of Indigenous healthcare providers, and these include members of the Indigenous Pharmacy Professionals of Canada. We fully recognize this is just a start to our Indigenous engagement journey, and we'll continue to work on and learn how to best approach furthering reciprocal relationships with First Nations, Métis, and Inuit communities and organizations who wish to learn more about our work or partner with us on appropriate use. And as we approach this Indigenous engagement work, we'll do it with respect, authenticity, humility, and seeking reciprocity. And during these engagements, what we did was shared our foundational strategy, our elements, and sought both validation and input on the draft strategy and any general feedback that we got. And we heard a lot of different themes. And next slide, please. Altogether, we held 11 engagement sessions ranging from targeted focus groups to an open registration public town hall earlier this spring of 2025. Through these different engagement activities, we reached over 250 people. And like Stephen said, this is on top of what the CDATO also engaged on. We built upon a lot of that work. Many of you would have either attended the town hall or other focus groups in that time. So I'd like to extend my thanks to everyone who's provided their time and input during the process. So what did we heard? Like Stephen said, I think these themes kind of resonated throughout the whole engagement journey, but these are four main things that really stood out. Their participants in general saw that the strategy's proposed actions are important, relevant, and really the right way things to start improving appropriate use across Canada. We learned that when we heard that trust plays a very important role in appropriate use. So how do we build trust both with our organization, between patients and providers, so to increase the uptake of resources to inform how people can make better decisions. We also had a lot of very engaged folks who really wanted to continue to be engaged in this work as we continue. So part of the process is this webinar and sharing it out, but also how do we continue to hear from people and get input, but how do we also share information back out? Maybe one of the final themes is people also wanted to know, as we proceed in our strategy and actions, what does success look like? And you'll see later on that actually one of our strategic priorities is evaluation and reporting. So now that we have set up kind of how we did the strategy, I will spend a couple of slides talking about what the strategy actually looks like. Next slide, please. So this strategy is really about how Canada's Drug Agency will support and guide pan-Canadian action by working with partners across Canada. And the idea is to drive change that will support patients, caregivers, and the public, healthcare providers, and also health system decision makers. Also importantly to note, this strategy is not guided by cost or intended to limit patient choice, and it does not weigh in on the appropriateness of specific medications themselves. So what are our goals for the strategy? So there are really 5 main goals, 2 of which are really to support public, patients, caregivers, and equip clinicians with evidence-based information so then they can make the best decision possible about prescribing and use of medications. Third goal is to support policies and decision makers in implementing evidence-informed appropriate use programs. all this to strengthen health system sustainability and to collaborate with health other partners across the system. And really by supporting clinicians, patients, and decision makers to make better decisions about appropriate use. This will also reduce potentially inappropriate use, meaning we could reduce overuse, which is when a person is prescribed a medication that they may not need. This would reduce underuse. This is when a patient is not prescribed a medication potentially available to them, but could offer a benefit to them. Also, this will reduce general inappropriate use as well, which is an umbrella term that includes medication use that do not adequately address care priorities of patients more generally. So an example of this could be the use of sleeping pills in the long term to improve sleep when they're really intended for short-term use. So those are our goals. And how are we planning to achieve our goals? I won't go through all the actions here, but these are 4 strategic priorities. The first one is through partnerships and program development. As you heard, there are many different programs here doing this work already. So how do we develop, enhance, and implement initiatives across the country with our partners? Connect. There are many groups here. So how do we link partners to enhance these connections, provide information about appropriate use? Third, strategy and policy. So developing evidence-informed advice and recommendations for decision makers about adoption and implementation of different appropriate use policies. And then there's evaluation and reporting. So again, how do we evaluate projects and clearly communicate their effectiveness, especially for new spread projects that we're doing? How do we evaluate them in a rigorous way? So again, you've heard a lot from me. And now I'll turn over to the panelists again to offer their perspectives. And this time, I think I'll start with Stephen. So if you could tell us a little bit about appropriate use challenge that you have seen, and how do you see the strategies for priorities helping address that challenge? And this will be the same question from different perspectives from each of our panelists. So Stephen, we'll start with you.
Thanks, John. That's a really good question. I think that the 4 pillars of the strategy, which again were verified through a lot of that engagement process, are really important for policy and decision makers because one, it can provide new evidence or bring together through a process of consolidating the evidence on particular issues and bring that to the attention of those who want to use that evidence for decision-making purposes. I would say another really important aspect of this is it's sometimes very difficult for policy and decision makers who work at a certain level of the system to really have a good sense of what's happening on the ground, so to speak, what happens in that dyad relationship between provider and patient, and how we can then, through that understanding, better support those people who are making those decisions on the ground with the kind of information they need. So as we better understand that process and those dynamics and bring that to the attention of decision makers, they're better able to act on it. I think another important thing is that the work of the strategy can help to engage decision makers and policymakers to understand the data that we have available, that we need to make available, as well as data gaps that really either facilitate or impede our understanding of appropriate use and our ability to act on it. And then finally, I think one of the real benefits of this strategy for policy and decision makers is the convening function, the bringing together of people across the jurisdictions to understand best practices, what's working in one jurisdiction, and the sharing of that information so that we don't duplicate each other and replicate what's going on, but learn from those lessons learned. So there are many, many things that I think policy and decision makers can really benefit from with respect to the strategy.
Thank you, Stephen. And Jim, same questions for you.
Thank you, John. So back in 1989, when I was finishing up my training, I'm a geriatrician, so a clinician in practice. My practice is divided between seeing people with cognitive impairment and seeing people with medication-related issues. I actually did a research project on appropriate medication use, 1989. And then when I got into practice, I knew it all, didn't I? But I discovered very quickly when people started coming in with their medication lists and their issues that I didn't really understand it at all. And I was really floundering at times when somebody would come in and say, here, I've got this article, or my neighbor told me about this, or my daughter told me about that. I shouldn't be on it. What are you going to do about it? And I didn't have the tools or the resources or the knowledge to know how to best address the question they were raising. It's early days for the strategy, but already work is underway. The CDA is taking a connect and partnership role in supporting the Appropriate Use Coalition that you'll hear about in a few minutes, which is a group of 11 organizations from across the country, each working to try to improve appropriate use of medications, previously each working independently. Their work has led to various organizations working together to develop programs and supports, including tailored resources for different audiences. Details will follow, but having groups working together rather than in isolation has been critical to development of new resources and starting to spread ideas across the country. How the strategy's priorities help include, as I say, the developing tailored resources. There are a couple that you're going to see on a slide shortly, the 5 questions for patients and the 5 tips for prescribers. One of the things that we did with Caden in the very early days was to say, if you're doing something with patients, you have to do something with prescribers, so that you weren't in the position that I found myself in when I first started in practice. The other thing I think that's really important is the provision of a consistent, credible place to go for information. And you'll hear more about that as well. There's lots of information on the internet. I have lots of people come in who've self-diagnosed, except they're wrong because they saw it on the internet. I have a daughter who's in the same position, actually, who believes everything on the internet. And having a credible place, which the CDA can provide, is really, really important.
Thank you, Jim. I really like that kind of pairing up, like if you're doing something for patients, also something providers to support them as well. And Connie, same question to you.
For me, as the patient at this table, there are too many patients that don't have the knowledge that they need to have. And it becomes very important that we educate the patient. And how we go about doing that goes back to Jim talked about earlier. Caton has a lot of resources for patients to use. We've referred to the 5 questions. To me, those are very important as we move forward. In my world, I've seen too many adults taking more than 5 prescriptions, and they're colliding with each other. And in today's world, those inappropriate use, they go to a different family physician because they've got a reaction. Then they get another pill that creates another reaction. So our patients need to have knowledge of appropriate use. They must also have the ability and feel comfortable with the 5 questions, which we are going to hear about shortly, I believe.
No, thanks, Connie, for teeing me up there. And I think what I heard there was really some of the convening functions and helping actually working with partners in collaboration. Stephen, you talked a little bit about reducing duplication potentially for that and making more effective interventions to support. We heard about the importance actually of educating and supporting awareness about appropriate use, that yes, this is something that patient can think about and can do something about. And Jim, again, kind of that as we build these tools together, how do we make sure we're supporting everyone and actually working through these appropriate use? Thank you for some of those reflections. Maybe I'll go back to the slides. Thank you, Kristen. So I'll now go and talk through a little bit of some of the ongoing work that we have. Like the panelists kind of mentioned, as we were developing the strategy, it was very important to us that we also get started with some work that will start improving appropriate use. So I'll be sharing some highlights of what we have been working on as well. And the questions and answer, please feel free if you have any questions about these to put them in the Q&A as well. So just to remind everyone, these are kind of our 4 strategic priorities. And I put this out here only to say, as I walk through the couple of initiatives, they all tie in to how we're working with partners to enhance, build tools, how we're linking partners together, how we inform decision makers, and also evaluation and reporting. So next slide, please. So the first here, and so I've talked about this a little bit a couple times now. There are a bunch of different programs out there. There are some loose connections between different groups here, but we clearly heard one of the first thing is, do people actually all know who's working on what inappropriate use? So one of the first projects we embarked on is to build an appropriate use program map, building on a lot of the work that CDATO did, and also our own outreach in these programs. So this is an interactive program map that's on our website. And really the idea here is they'll support different programs if they're looking to say, hey, is someone else doing audit and feedback? Is someone else doing clinical tools? To go on here and say, oh, maybe I should reach out to this. So a inventory interactive map that could facilitate that. Since its launch, we have about 33 programs, and this continues to be open. So later on, if you do go on the program map and you see, oh, I don't see this service here, please do email us and let us know, and we can add them to the program map. And we have heard from our partner that this is actually a useful and wonderful resource for them. So we have heard some positive feedback since we have released it. Next slide, please. So building on that kind of connection theme, the first one was really kind of that loose connection we're providing. The second here on our appropriate use coalition is a much deeper and intense effort on this. So the appropriate use coalition unites 11 organizations who are all committed in some way to improve the appropriate use of medications across Canada. So we at Canada's Drug Agency Service Secretariat is co-chaired by Dr. Wendy Levinson from Choosing Wisely Canada and Dr. Emily McDonald from the Canadian Medication Appropriateness and Deprescribing Network. This is work that's been ongoing actually before Canada's Drug Agency started, and now again, like I said, we're Secretariat support. One thing that they have actually looked to support and focus on in the first couple of years is to focus on the improvement of appropriate use of antipsychotics in a long-term care home setting. So since this group have really been working together on this, you can see all the logos of the different organizations there. They have launched a quality improvement target for appropriate use of antipsychotics in long-term care. There's been a series of webinars to support long-term care homes and clinicians to reach those targets, and work is continuing to build on this. So really this demonstrates how these organizations can work together for greater collective impact. And maybe we can also drop a link to the long-term care ltcmeds.ca website if folks are interested. So moving to our next slide, and both Connie and Jim talked about this a little bit. So maybe I'll define what polypharmacy is first. This is really about the use of 5 or more medications, commonly defined as polypharmacy. While it could be perfectly fine and appropriate for people to be on more than 5 medications at the same time, but we also know that sometimes it can be unnecessary, and we also know that as the number of medications that you're taking go up, so does the risk of adverse drug events, falls, hospitalizations. So to really start building awareness about this issue and what the potential risks are, we have partnered with ISOP Canada and deprescribing.org to build these 5 questions for patients to look at to support them in having conversations with their providers about polypharmacy. And on the counterpart, 5 tips for clinicians on how to manage polypharmacy. And another kind of example of how we're harnessing collective impact, we also worked with Caden on a public-facing webinar. So these are for patients and community members on a webinar to share these resources out. So that took place in October. We had 189 registrants, and over 80% of poll respondents thought the tool was very useful and that they would like to share this out with their friends and family or use them themselves. So next, I'll switch over from clinician tools to something that's a little bit more at the decision maker kind of audience level. So these are appropriate use intervention summaries. So we all know that there are different interventions out there that can support the improvement of appropriate use. However, how they're implemented, what the evidence is behind these interventions are sometimes hard to find, and what the best practices are. So these intervention summaries are really snapshot of the evidence best practices and some examples across Canada on what these interventions could look like. So for this set, we focused on academic detailing, audit and feedback, clinical education, and clinical decision support tools. And we really built this work with Women's College Hospital Institute for Health Systems and Virtual Care. Sorry, there's so many acronyms in healthcare field. So you may know them as WEAVE. And we leverage a lot of this work through what CDATO did with WEAVE during that time. Next slide, please. So again, another tool, or I guess program that's really geared towards decision makers is the Appropriate Use Resource Program. So as you know, there are many different appropriate use topics out there, including specific issues that are happening in maybe a specific healthcare setting, like a hospital or a dental care setting in different clinical areas. The resource paper program is really meant to shine a light on some of these issues where they miss some gaps of understanding and to create a baseline knowledge of these topics for decision makers and other health system leaders. These papers will identify key issues, insights and analysis, and offer potential evidence-based interventions on improving these issues in different settings. So we're currently actually working with a research group called Gemini out of Unity Health in Toronto in producing a paper around appropriate use in the hospital setting. And we're also just starting work and one on dental care as well. So look forward to, I think the Gemini one is slated for early next year, and the dental care one we have just started. And finally, this is a little bit of a look forward into other partnerships and program development, and also with the evaluation and reporting piece. We're working with 4 academic detailing programs from British Columbia, Saskatchewan, Ontario, as well as Nova Scotia. And so academic detailing is interactive education sessions where typically pharmacists would go to clinicians to support them in doing practice change. And it's an unbiased way to provide evidence-based information to clinicians. So in working with these 4 academic detailing organizations, the idea is how do they work together again on developing and selecting a topic so that they can actually influence prescribing behaviors on a high priority appropriate use topic to all 4 jurisdictions at the same time. And also how do we foster this collaboration so we can co-develop a replicable process in working together in the future. This group of 4 academic detailing organizations do work together already, but really just about how do we kind of strengthen that collaboration in working together. So again, that's a taste of some of the projects that we're working on. And maybe now, I believe I'm turning it over to Katie, who's been curating some of the questions on the side.
Yes, thank you. So we have one here with a few different upvotes. Curious about requiring indications or purposes of treatment on prescriptions. So for example, including why a medication was prescribed, and what people feel about making that mandatory, the value of doing indication-based prescribing.
Maybe I can start, and I'll also maybe turn to Jim as a clinician as well. I don't know if we'll be in the position to mandate this. I don't think that's really a role, but I can reflect on the work that we did for polypharmacy. Actually, if you look at the first 2, both the top 5 questions and the top 5 tips is about what is the purpose of each of the medication and making sure that you're documenting the reason for use. So I think clearly those are very important concepts out there. Maybe Jem, I'll turn to you just kind of on your thoughts on that.
Oh, sure. So I referenced that I did a research project back in 1989. And what the research, it was very simple. What I did was I did chart reviews for patients on units in a care center, and I matched the indication and the drug. And then I provided feedback to the prescribing practitioner on the drugs where there was no indication or no obvious reason for use. And that became the basis then of looking at whether or not we could deprescribe certain medications that clearly people had been on historically, but where there was little or no information about why. I personally believe we should have indications on every prescription we write. In my reports that I send back to the family physicians and others who refer to me, every medication is matched to the indication because it gives a much better picture then as to what's actually happening with the individual. As you say, John, we can't mandate it. There's been lots of discussion at jurisdictional level about this. But personally, I believe it's something that we should be striving to do.
Connie, I think you have a comment on this too.
As a patient here, I strongly agree with Jim because I go and get a medication from a practitioner, we'll call it. I get a 3-page written at a level that I, with a master's degree, can hardly understand. And in all of that, I forget at some point, why am I taking this pill? And we need to keep repeat, because many of us, well, I'm not even sure it's as we age anymore, forget why we're taking one of the pills we're taking. And then what? So I agree. I'd like to see it happen. I'm not sure it's going to be written in user-friendly language, which is part of my real concern in this whole appropriate use.
So even that definition, how do you, for what it's for, can a patient understand what it's for? I think it's what you're getting at there too.
Absolutely.
And Stephen, I wonder, like in kind of a lot of your work that you do in the system level, is that something that you have heard from kind of other work as well?
Yeah, we heard that for sure during the engagement processes. I think both for the Canada Drug Agency Transition Office work and also the work that the Canada's Drug Agency did when we went out, we heard this very much, this whole idea of whether those indications should be there. We heard about off-label usage, et cetera. And so it is very important at a system level. And as you identified, John, at the outset about the high cost of providing medications to people that they actually don't even require. We don't want to do that. We can't afford to keep doing that.
Perfect. Thank you, everyone. Katie, any other questions for us?
Yes, and one that segues onto a comment Connie made. A question asking, most patients may not understand what medication appropriateness is. How is inappropriate use defined in the strategy, and how will the strategy address prescription habits that may contribute to inappropriate use?
Yeah, maybe I'll tackle that. How are we defining inappropriate use? And I think broadly we see it as kind of conceptually 3 pieces. One, and I think I mentioned a little bit earlier, it's really about when a medication is used or prescribed that's not necessary. So maybe a kind of specific example on that is using antibiotics for a viral infection, right? So that's a potential for overuse. The other way we're thinking about it is there are also instances where inappropriate prescribing use is that someone did not get a medication where they should have. So there are a couple different examples. I think one that we have talked about on and off actually recently is asthma treatment. So if someone is not using their asthma treatment on a regular basis, can it exacerbate? Do you end up in the ER instead? So that's another example. And then more broadly, there's also just the umbrella term may not be super helpful about inappropriate use. So I think about this again, long-term use of benzodiazepine, or again, going back to antibiotics. Yes, you may need antibiotic to start, but the duration of antibiotic use may not be as long as needed now that there's no evidence on it. I don't know if I answered. I don't know if panelists have anything to add to that. Maybe I'll pause. And Katie, I don't know if I got the second part of the question.
Maybe I'll jump in, John.
Yes, please, Jim.
So part of the reason that we did the work to found Caden was because we wanted to be able to provide appropriate evidence-based education to both patients and practitioners around how to approach appropriatizing. I'll use that. It's not a real term. I know that. their medications. And as I said, the focus was on both together. I think the answer to much of this, because the second part of the question was about working with prescribers, John. I think the answer to this largely is education. The issue is how to provide that education in a way that's going to get through to the people that need to be receiving the education. We're not terribly good at that. And so doing a number of different strategies and having a number of different mechanisms available. I mean, when I talk to residents now, the first thing that happens is the PDA comes out because they're going to look something up. So that's one mechanism. There are others who want to have something handed as a one-pager to them. They can look at it, an algorithm, whatever it might be. So we really need to be thinking about it from the perspective of what are the different mechanisms that we can use that are going to actually help us to get to where we need to go. Audit and feedback is another one. Audit and feedback actually incorporates looking at an individual's practice with education. I mean, at the end of the day, education is a piece of all of this. And as I say, it's really just getting to what's the best mechanism and how do we reach different audiences in different places.
Jim, thanks. And maybe I'll build on that a little bit too. And that I think just on practice, when we're developing tools and resources for prescribers and for patients, a part of our philosophy is really developing and co-developing these things with prescribers and with patients, because I don't think there will be ever an instance where we're going to be developing any tools for them without really input on that. And I think part of that, Jim, you have articulated is not just what it'll look like, but how do we get it into the hands of people who need it in the easiest way possible, and maybe embedding it into their workflow rather than something new. And it's easy to say, but I think hard to do, and it'll be a challenge for us to do that. But I think something we're striving for.
There's quite a lot of interest in the indication-based prescribing conversation. So a comment, more a reflection that having the indication on the prescription may help avoid awkward or sensitive situations, and curiosity about, encouraging and training pharmacists also to ask for why a prescription may have been given.
Yeah. Jim, I don't know if you wanted to kind of chime in on that piece there.
Well, so the only comment I would make, I mean, I think a pharmacist isn't going to be able to read the mind of the prescriber, and that's part of the challenge. Asking an individual why they've gotten a prescription may be fine, but I entirely agree with the comment in here. I know when I go in and I pick up a prescription, I get asked about it, and the three people in line behind me are all hearing everything we're saying. And so I think we need to think about how do we revamp the approach to dispense without undue costs and all the other sorts of things that go into it, but in a way that some discussions can be held that are confidential, because they should be confidential. And that's another piece of all of this. I mean, ideally, if we could get the prescriber to put the indication on the prescription, it would go a very long way to helping to sort this through. But if we're going to look at workarounds, basically is what I'll call them, we need to actually facilitate the workaround so that it actually works for the individual.
Connie, please.
We also need to encourage the public, people like me, to ask the questions. It's my body, it's my prescription, and I need to know whether I ask the doctor, who is the prescriber, or I ask the pharmacy. I see pharmacists today doing patient pharmacy conversations. Come and talk to me over here, which gives a little bit of privacy, which to me, we need to encourage that. We need to empower the patient to ask the questions. Thank you.
Connie. Stephen, anything to add on top of that?
No, I don't think so, John. I don't think I have anything to add to what they've said.
And maybe a little bit of a side on this whole indication and data and measurement. I know there's probably a lot of folks who is interested in measurement more generally. And I think one of the, I come from also a data analytics background before this. One of the challenges of actually measuring appropriate use is really without indication in the data. It's very hard to say what is appropriate and what is not appropriate. So I think I'm just kind of identifying a general challenge and when we're measuring this work.
Which is also a great segue to another question.
And that was not planned.
Yeah. During the engagement, many people asked what success would look like. So how can the success of the 5-year strategy be measured? And are there indicators for that?
No, that's a really great question. And I'd say that, as you saw, that evaluation and reporting is one of the strategies for priorities. At Canada's Drug Agency, we're also accountable for monitoring and reporting our work back on our strategy through semi-annual progress and performance reporting back to Health Canada, who is one of our funders. And also the Pharmacare Act within it also notes that we have to provide a 3-year progress report back starting. So I think the strategy was launched September 18th, so 3 year from that date. In terms of indicators, we do not have kind of specific indicators at this time, but one of the things that we know we'll be looking at as we have larger scale or even smaller scale spread projects, it is important to us that we're actually looking at those specifically and evaluating those to see those projects are spreading the way we're intending for them to spread.
There's a number of questions on the theme of knowledge translation and knowledge mobilization. So perhaps I can bundle them into John. Can you speak generally to sort of the knowledge mobilization and translations kind of strategies and activities within the strategy?
Yeah, so that's a very important and excellent question. And I think we spoke a little bit, right? Like Jim and I about how do we get these into the hands of the folks. So I think we are in process of actually formalizing a little bit more or having a more systematic way in thinking about how do we actually disseminate this information. But maybe I'll speak a little bit to some of the ways that we have done them so far. So one, I think, is really meeting people where they're at. So we've started to reintroduce ourselves to some conferences where there are key clinician audiences. So we're at a Family Medicine Forum recently. How do we use social media channels and our partners? And I'll go back to that whole partner piece of it. Like there are a lot of people in this space who are much better connected to clinicians already. So choosing Wisely Canada, for instance, to clinicians, Caden to public awareness, and also they have a very, very more established indigenization program on there, and deprescribing.org has specific audiences to pharmacy. So part of it is going to be leveraging our partners and how do we get this information out. So maybe I'd say we're still in the works exactly what that would look like, but we are looking at all different avenues and how we do it. And part of it is also just starting early and thinking about actually where are people getting this information and really building it to the very beginning. Any, oh, please, Jim.
Yeah, I'd make the other comment that part of the intent here is to also spread and scale. And so there may be things that people are doing locally that are effective that we can learn from and adapt and adopt along with the things that we're already trying to do. As I said earlier, this is early days, but I think that the group is a very open to learning group. And so please share if you have ideas or thoughts or whatever. And as we do our work and we'll reach across the country, we will come up with things that we'll also then be able to conversely share back out. All of that, I think, is going to be important.
Thanks, Jim. And Stephen, I think you wanted to chime in here as well.
Yeah, I just think one of the benefits really when it comes to knowledge transfer, knowledge exchange is really bringing some coherence to the many, many initiatives that are already existing. So we know from the CDATO process, I think the Secretariat had identified about 50 different initiatives that were going on at that time across the country. Some smaller, some larger. So really trying to understand what is happening, being able to bring some evaluation to those efforts to really understand what is able to spread and scale over time, and then bring some of that the summary of the evidence back to decision makers who can potentially act on it. So there's a really nice way of trying to bring some coherence to a pretty active field, actually. There's a lot going on, but we don't really have a good understanding of what that actually looks like when we try to bring it all together and bring those threads together.
Thank you, Stephen. And I think, Connie, you have a comment on this, and maybe after this, we'll kind of move on to final thoughts. But Connie, please.
I'd just like to point everybody to the Caden resources, because as a patient partner at this table, I'm also on that Caden team. And I have learned so much about what I need to do as an older person, and the resources on the Caden website can be used by probably everybody on this call. Just be aware of those resources. Thank you.
Thank you, Connie. And maybe before I pass it on to our panelists for final thoughts, I'd like to thank the panelists for joining us and offering your insights and wealth of knowledge. Thank everyone for participating and being engaged with questions, and the whole CDA AMC team for making this possible. So with that, maybe final thoughts. I'll start with you, Stephen.
Okay, thanks, John. I think this is tremendously exciting work, and it's work that has to be done. And as I said, there's a lot of work underway, but I think we're going to bring better coherence and collaboration around this effort. Healthcare in this country is facing a lot of challenges right now, and I think appropriate use. It's really helpful to consider appropriate use within the context of the quintuple aim, right? So thinking about how we use our resources as wisely as possible and get the best value for money for the significant amount of money that we're spending in healthcare in this country that is significantly taxpayers' dollars. Getting the best patient outcomes that we possibly can from those resources. Supporting providers who do their work to reduce administrative burden and actually be able to serve the people that they are most effectively, as well as providing opportunities for collaboration and coordination amongst those providers. And then also really improve, this also will have the effect of improving the experience of care for patients and addressing issues of overuse and underuse. And then finally, really helping to advance health equity when it comes to appropriate use. I think also what's very exciting about this is that the legislation that created Canada's Drug Agency also identified appropriate use as a priority. And so this is now core to what the CDA does. It is not just something that we're doing for a time. It's core to the mission of the organization. And I think that's really tremendously helpful as a pan-Canadian organization to pull people together, to convene people together, to identify the knowledge that we already have out there, and in some cases to invest in new knowledge syntheses so that we can get a better understanding. And finally, I would say what's really exciting about all of this is that this is one of those opportunities we've had in Canada where we've gone from engagement to advice to strategy development, and what is often the missing step now, implementation. And so it's really exciting for me, certainly who's been involved in this for a while now, to see that move from engagement to advice to strategy to implementation. And then ultimately, as we continue to go forward, to evaluation and looking at impact. So thank you.
Thank you, Stephen. I'll go to Connie and then Jim.
For me, knowledge is power. Each of us that have listened to this information or are involved need to encourage our friends, family, and colleagues to ask the questions. It is safe to ask questions, and we all need to be asking those questions. Do me a favor, leave this webinar and go tell somebody what you've learned today. Thank you.
Thank you, Connie. And Jim.
I don't have much to add, actually, but as a clinician, I'm well aware that when medications are used appropriately, they can have great benefit. They also have the chance to have harm when they're not used appropriately. I've worked my whole life in this area. I can only say that when we started Caden 10 years ago, 11 years now, I would never have envisaged we'd be in a position where nationally we would be talking about appropriate use of medications, and trying to make a difference for patients and prescribers across the country. And I'm very pleased to see we are where we are, and early days, but I'm really looking forward to where this ends up going.
Perfect. Well, again, thank you, Connie, Stephen, and Jim. On this one, on that note, we'll close and thank you everybody for joining us today. Have a good rest of the day.